sternotomies and the chest cultures. First, I want to talk about the emergency sternotomies. And, of course, I'm only going to be talking about intubated patients because extubated patients you're obviously going to call a stat to come and put it back to sleep. So this is what's recommended what we recommend that you give during patients that are having an emergency sternotomy. Now, I recognize that most of these patients are going to be they're usually pretty unstable and they're starting to, circle the drain. And sometimes you're not even going to have enough time to do this. Often in the ones that are crashing, you might not have time to do this. The ones that you do have time, it would be nice to be able to give them ketamine. And I'm going to go over exactly, what ketamine is and what the side effects are. And then give pancuronium. If they're stable, then I would probably give them fentanyl and midazolam. But oftentimes these patients, I know, are not stable. And if they're not stable, one of two things. One is either you're not going to give them basically anything because you're going to be working giving blood and trying to resuscitate the patient, or if they're unstable, you can just keep giving every 10 or 15 minutes little doses of ketamine. And let's just go over ketamine. It's an anesthetic. We use it. Sometimes we use it for a sole anesthetic for a procedure in the operating room. It causes a dissociative state, and what that means is that it's directly acting on the brain to dissociate the patient from their environment. So they can be looking at you, their eyes open, and you can do this. You can talk to them, and they are not there. So that's a direct effect on the brain. And the side effects that it has are the things that we like to use in cardiac anesthesia, and we'll go over those in the next slide. So it causes amnesia. These patients do not remember anything in the dose of 1 milligram per kilo. They don't remember anything, and they do get some pain relief, although it isn't a substitute for using fentanyl or one of the other narcotics. But it does have some analgesic properties to it. It causes bronchodilation, just interestingly, it does, and we use it to put patients to sleep that have severe asthma, so they don't get bronchospasm when we're giving them anesthesia. Its onset is very quick as soon as you give it, basically, and it can last 10 or 15 minutes IV. Okay, the side effects that we're most interested in are these top three, because these help us maintain cardiac output in the cardiac patients. It causes tachycardia, it causes hypertension, and we say use with caution in patients that have hypertension or uncorrected LVOT obstruction. It's not contraindicated, I would just use it with caution. It increases cardiac output, another plus that we like to use it for. The increases in SVR and PVR, the increase in SVR obviously is helpful. The increase in PVR in patients that are being ventilated and that can be hyperventilated and blow off some of that CO2, the increase in PVR isn't appreciable. So it's fine to use in the patients who are worried a little bit about PVR because they're all going to be mechanically ventilated. And one of the side effects that's a real problem for us is that it causes a lot of secretions. The patients that are intubated, it's probably not an issue, although if it is and it looks like, it's copious, they're dripping out of their mouth and you're afraid maybe the tube might slide out, you can treat them with glycopyrrolate or even atropine in the same dose, and they will dry up secretions, 10 mics per kilo.
Would that precipitate tachycardia?
It would
on top of the ketamine?
Glycopyrrolate doesn't cause as much tachycardia as atropine does, so that's why we use it. It might cause a little bit. But usually with these kids, we're not so concerned about the tachycardia, unless it gets pretty high. The trade name for that is Robenal. I don't know if you've used it much here. Okay, one side effect that I want to mention that hopefully you don't see too much here are patients that are kind of in a chronic low output failure at home for months, who are kind of the failure to thrive, real sickly looking kids that come in. We don't want to give them a lot of ketamine because it can have a direct myocardial depression and cause hypotension. In the average cardiac, post-op cardiac, it's not going to be an issue. But kids that are, the kind of kid that we don't do it, the kind of kid that we would do it on is somebody who has been on diuretics and DIG for a long period of time at home and isn't thriving. We wouldn't probably use a big dose of ketamine with them. And actually we use a lot larger doses in the operating room, up to 10 per kilo. We give them IM before we put them to sleep. We wouldn't do that a patient like this. But I think for most of the patients we're dealing with up here, ketamine should be okay. More side effects. A big one, especially in older children, is the bad dreams and delirium. It really helps to have a benzodiazepine given right about the time you're giving the ketamine. They can wake up wild, and it's just a known side effect. The other side effects here, well, respiratory depression, laryngospasm, you're not going to see that when the patient's paralyzed. So just kind of for completeness, I'm telling you this. One big one is the increase in intracranial pressure. Anybody with any suspected intracranial pathology probably shouldn't get ketamine. And it also, you won't see either of these two when the patients are paralyzed, but they can, without being paralyzed, they can make some, just really kind of weird movements. They can look like seizure activity. They can get nystagmus. Their eyes are wide open and they're just flicking over to the side. That's very common, but again, you won't see that in a paralyzed patient. Okay, so the next drug, does anyone have any questions about ketamine? Okay. The next drug
I do. Is there any cumulative effect? If you say you can give it every 10 to 15 minutes, is there any cumulative issues?
I wouldn't think within the hour to two that we're talking about, no, because patients are run on infusions of it, and these are pretty low doses. So I think with that dosing, I think you should be okay for an hour or two. If we were talking about, infusions, I could give you that dosing too, but I think for just this procedure, no. Okay, so
I'm sorry, Lori, what would the dose of ketamine be for an older child?
Same.
It's always
same for
an
adults.
adult.
Yeah.
1 per kilo.
Yeah.
Okay.
And it's recommended that the sedation dose is 0.5 to 1 milligram per kilo, and the anesthetic dose is 1 milligram to 2 milligram per kilo IV. So we're right, you're right on the border. We give, in the operating room, if we had a patient that had an IV, we would give 1 milligram per kilo.
So are kids coming back, let's say we had a Fontan that went sour, I mean, that's kind of a chronic kid that's been on diuretics, would he still be okay for?
Coming in from home?
Yeah, for ketamine.
I don't know, it seems like most of the Fontans that we're doing are not, yeah, if they don't go to get their Fontan if they're not doing well. So it's usually, if anybody, it's usually like the ABSDs that are kind of maybe 6 or 7 or 8 months old that just aren't thriving. That's the first one that comes to my mind that I would, usually the hypoclasts are not in that category. Fontans come in and are doing pretty well, same with the Fontans, so. Okay, so let's just talk, I know you all use pancuronium, but just to review it, it's our longest acting muscle relaxant. It does cause tachycardia. The onset, it's not as quick as some of the other agents, so if you give pancuronium, you're going to have to wait about 3 minutes for the surgeons to be assured that the patient won't move. And what we usually do is tell them, if they want to go right ahead, is just, the pancuronium's in, it'll just take a minute to finish, to take full effect. It's starting to work, and they just go on. So just remember that it's not immediate. And the duration of action is anywhere from 40 to 60 minutes, but I'm sure as all of you know that sometimes you have to redose that, 15 or 20 minutes after you've given it. And there's no harm in patients that are being ventilated for several days in giving, an overdose of Cabulan. So it's recommended that you give 0.1 per kilo and then in a half an hour to 60 minutes give another dose. But if you need to give it earlier, there would be no problem with that. Just remember that all the patients, sometimes the patients are spontaneously ventilating or breathing over the vent or with the vent, and when you paralyze them, make sure you change the settings. And that will also help with the ketamine and the PVR issues if you make sure you just put them on a regular vent settings for a paralyzed patient. Okay, the next thing, once they're stable, give fentanyl at 5 mics per kilo. It's a just to go over fentanyl, it's a narcotic, it's fairly short acting, it lasts 30 to 60 minutes, and it may cause hypotension, so make sure you only give it when they're stable. It's especially potent when you combine it with midazolam. If you combine them both together, you can really see the pressure bottom out. So if they're not stable, and a lot of these emergency sternotomies are not, I would not give fentanyl. The other big side effect that you all should be aware of for any time you're dealing with fentanyl is that if you give it rapidly, even in doses of 5 mics per kilo, you can get what's called chest wall rigidity, where you can't ventilate them at all. You can't mass ventilate them, you can't put them on the vent and ventilate them. It's just a rigid chest, and it's quite scary if you've never seen it before. So always give pain cure on you before you give fentanyl. And all that means is in the line, you give PAV followed by fentanyl. It's not like you have to wait the 3 minutes till the PAV works, just as long as you give the Pavulon, follow it with the fentanyl. And that's the way we do it in the operating room. Also, titration. We always talk about in anesthesia, everything gets titrated. And I know up here you probably aren't as familiar with titrating, but the way we do it is just to give 5 mics per kilo and then wait. It's not going to be immediate, the effects. Wait 5 or 10 minutes, check out the heart rate and blood pressure. Usually those will be your most sensitive signs, especially blood pressure. And then if they're still hypertensive, give another 5 mics per kilo. And then keep repeating that. And in these patients, you can go up to 20 mics per kilo safely, I think. Okay, so again, then you need, if you're not going to be giving any more doses of ketamine because the patient's fairly stable, you're going to need to give something for amnesia. So give midazolam. You just go over it. It's a benzodiazepine. It's pretty immediate in its action, and it lasts, again, half an hour to 60 minutes. Some reports actually say up to 2 hours, but I would redose it after an hour for sure. If the patient's not intubated, it can cause respiratory depression, and again, remember that in combination with fentanyl, you get hypotension. So just give it separated in time. I usually give the fentanyl, make sure the patient's stable, 10 more minutes later, and then go ahead and give the midazolam. Okay, and again, we talked, if the patient's unstable, don't give the fentanyl midaz. Just give little hits of ketamine if you're able to.
And because they're PAD, they won't have the emergence type issues.
You know, they will if you. Okay, well, the emergence type issues, well, they haven't been reported in neonates because obviously neonates can't tell you. So it's reported to be less in young children than in older, and I'm not sure if that's just the reporting issue. But I probably would not, if the patient's unstable, just give them the ketamine, and once they're stable, they're either going to not do well or they're going to get stable, and then you can go ahead and give them the benzodiazepines.
Somebody had a question in regards to if the ketamine only lasts 10-15 minutes, and then you're giving the PAD and the fentanyl, and you're waiting between the fentanyl and the midazolam, will we end up giving the midazolam too far out from the ketamine?
Yeah, you know, the amnestic effects of ketamine can last longer than the 10 to 15 minutes.
Okay.
So I think you're probably okay. In just kind of spacing it out every 5 minutes in there. I think you'll be able to work it out. I don't think that'll be a problem. Okay, so for chest closure, it's pretty much the same, you know, kind of steps that you follow. So I'm not going to go over each of those except to increase the narcotics infusion. And this is, I guess the problem in chest closure has been that some of these kids are on narcotics for a long time and they have developed a tolerance to them, and you want to, you start giving the fentanyl and they don't seem to be touched by it at all. And so this is why I think it'd be a good idea to increase what their baseline level of narcotics going in is. So usually if your fentanyl's down to, I'm not sure how low you guys get, but go back up to 10 mics per kilo per hour just for the time, for the 6 hours around the time of the chest closure. And increase your morphine to what we do in the operating room at 30 mics per kilo per hour. Give ketamine. This will help with the problems with patients that are sensitive to fentanyl. Just give them the ketamine to put them kind of off to sleep, and then go ahead and give the rest of the kind of the fentanyl midaz, which will be the rest of their sedation. So give them the pain again before the fentanyl. And in these patients, I would recommend going for patients that have had an open chest less than a week. They're probably not going to have developed tolerance yet. So patients, they can just have the same recommendations as the emergency sternotomy, maximum of 20 mics per kilo. So actual 4 boluses of the 5 mics per kilo would be good for those patients. Patients that are chronically have a chronic open chest greater than a week, I would recommend going up to 30 mics per kilo. Patients that are on, you know, these 45-day open chests, they are probably going to fall into this category where it's going to take an awful lot of fentanyl to